The discussion is going to be looking at what happened in this case and kind of explain physiologically what's happening. So one of the important things to remember is that blood glucose is homeostatically regulated, and in order to have homeostasis, you need to antagonistically move blood glucose. We have two antagonistic hormones, insulin and glucagon. Insulin is the hormone, sometimes known as the hormone of abundance. It is released when blood glucose goes up. When glucose raises, insulin is released from the beta cells of the pancreas, and that lowers blood glucose back to the set point. The set point, well, in this case, is the dotted line, right at about 100. Yes, that's a little excessive, but just for the purposes of illustration, it's a nice, easy number to kind of move around. If blood glucose were to go down and were to go below a normal value, then we would release glucagon. Glucagon comes from the alpha cells within the pancreas, and that's going to raise blood glucose back up towards normal by affecting the liver and releasing blood glucose from the liver back into the bloodstream to increase it. I guess it would be not blood glucose, but stored glucose from the liver and back into the bloodstream. So when we do a normal glucose tolerance test, you want to do a 12 to 15 hour fast, and the normal value we'd expect to see is 70 to 99 milligrams per deciliter. So 70 to 99 milligrams per deciliter would consider a normal fasting value. This figure just shows the pancreas. So the pancreas has both exocrine and endocrine function. The endocrine function of the pancreas includes alpha cells, beta cells, delta cells, and not shown here, F cells. But the ones we're interested in today would be the insulin is produced by the beta cells of the pancreas. Secretion of insulin is affected primarily by increased plasma glucose. Will also change your sympathetic or parasympathetic system in order to change the secretion of glucose. Glucagon is secreted by the alpha cells. Both the alpha and beta, the delta and the F cells, are found in the islets of Langerhans, or also known as the pancreatic islets. Those are the exocrine cells of the pancreas. And glucagon is also released by changes in plasma glucose or changes in the autonomic nervous system. As mentioned earlier, insulin is also known as the hormone of abundance. The goal of insulin is to decrease the concentration of glucose in the blood. So as the blood rises, the insulin is released. The targets for insulin would be liver, any type of muscle, primarily skeletal muscle, but also including smooth cardiac muscle, and the adipose tissue. As an example, excessive glucose would be stored as fat, and so the adipose tissue would need to convert that into fatty acids, which then would be stored as triglycerides in the adipose tissue. Note, the targets are not the brain, kidney, or the intestines, and that's primarily due to the fact that they don't have receptors for insulin. So insulin does other things as well. It increases the rate of glycolysis, it increases the rate of glycogenesis, it increases lipogenesis, and it increases protein synthesis, all of which would help you in terms of exercise and exercise performance. Glucagon tends to be the dominant hormone during fasting. Its goal is to increase the concentration of glucose in the blood. The only target it has is the liver. Why? Well, the answer to that is fairly simple. It is the receptor that gives the effect, and the only place we find glucagon receptors is in the liver. Glucagon increases glycogenolysis, which means basically we're breaking down glycogen into glucose, and then releasing it into the blood. And also it increases gluconeogenesis. That means we're making new glucose, which will also be released in the blood. That's primarily done through the liver. Well, there's also some of that done with the kidney. So again, to quickly review our procedure, the glucose tolerance test, we measured fasting glucose. That was T0. We put fasting in parentheses because we did not require the students to fast, especially the ones later in the day. It's unreasonable to ask students to fast for 12 hours for an evening class or an afternoon class. The students would then ingest a glucose load. In this case, it was approximately 80 Jelly Belly jelly beans, equaling 80 grams of sugar. We then measure the blood glucose and the urine glucose after 30 minutes, and then continue to measure the blood glucose every 30 minutes for the next couple hours. A normal test would have the expectation that the blood glucose started out below 100 fasting, between 70 and 99, and returned to that level sometime within 3 hours. So here's an example of a typical normal test. Again, looking at the fasting conditions. That's right here at time 0. The fasting conditions, let's go back. The fasting conditions right at 70, and remember we said 70 to 99 is normal fasting. For the pre-diabetic condition, it's right at 125, 100 to 126 milligrams per deciliter would be the pre-diabetic condition, sometimes known as glucose intolerant or impaired, but the more common terminology nowadays is pre-diabetic. The idea for pre-diabetes would be to maybe alarm the patient so that it sounded serious and they started doing something a proactive way towards fixing it before they actually became diabetic themselves. The diabetic level is 126 or above, and we can see when we ingest the glucose, the various patterns. Again, a normal test would start out between 70 and 100 milligrams per deciliter, peak within 30 minutes. The height of the peak is really not that relevant, just that it reached a peak in 30 or 60 minutes and then was back down below 100 within 3 hours. The pre-diabetic patient would start their blood glucose between 100 and 126 milligrams per deciliter, usually peak sometimes in 30, but especially the 60 to 90 minutes, and still be above the 100 level after 3 hours. And the diabetic would have a blood glucose above 126, and then peak sometimes not at all, or very late, in, an hour and a half or 2 hours, and have a often extremely high blood glucose after the 3-hour test. So when we look at blood glucose levels and we use the fasting level to diagnose different conditions, the numbers that we'll typically see, if we have 69 milligrams per deciliter or below, the term we use with that is hypoglycemic. Hypo would be low, glyce would be sugar, right? Emic refers to blood, so hypoglycemic, which just means low blood sugar. The typical causes of that would be too much insulin. Very uncommonly, it could be too little glucagon. This case is not often seen, and most often occurs in people that take insulin in terms of their managing diabetes, and they overinject insulin for various reasons, and the blood sugar drops. As mentioned before, 70 to 99 milligrams per deciliter is normal, while 100 to 125 milligrams per deciliter is known as pre-diabetic. Those are people that have impaired glucose tolerance. And then the clinical definition of diabetes mellitus is 126 milligrams and above. Just a quick note about diabetes mellitus. It translates into basically, it means honey tasting, free-flowing siphon. The diabetes refers to the medical symptom of having large amounts of urine excreted, while mellitus refers to the sugar in the urine because of the lack of the ability for insulin to either be released or to have an effect on the cells. So that excessive sugar is excreted in the urine. There is another form of diabetes. It's called diabetes insipidus. It has to do with changes in antidiuretic hormone. Diabetes mellitus is the most common form of diabetes, and in fact, when somebody just mentions diabetes without saying anything else, 99 times out of 100, they're referring to mellitus. So oftentimes, some people say mellitus, but oftentimes either one works. But just plain old diabetes referring to that. Additionally, both the pre-diabetic condition and the diabetes mellitus are considered hyperglycemic. So anything at 100 milligrams per deciliter or above is known as hyperglycemia, which is just a clinical name for high blood sugar. So we've already looked at this graph and explained what we see in terms of the responses and how we expect our patients, subjects, in this case students in the lab, to respond. So diabetes is characterized by elevated glucose, as mentioned. There's a number of different translations, but as kind of mentioned previously, diabetes means lots of urine, and mellitus refers to sweet or honey. There are two major causes of diabetes mellitus. One is the inability to produce insulin, where our beta cells of our pancreas no longer produce sufficient insulin. The other way to do it is the insensitivity of insulin receptors. This is where we make insulin, but our receptors don't respond to it, or can't respond to it, or don't respond sufficiently to it. So the insulin does not have as large an effect on the cells as they should. Symptoms of either type of diabetes includes hyperglycemia, that high blood sugar we talked about, glycose or glucoseuria, that is glucose in the urine. So pretty easy word to decipher. Gluco or glyco refers to sugar, urea refers to urine. We get an increase in lipid and protein metabolism because we're using less sugar for fuel, less glucose for fuel, and that could, result in ketoacidosis, especially in severe cases of diabetes. Because of the glucose in the urine, it has an osmotic pull of water, so we get what's called polyuria. Polyuria literally means many pee, and so we have an excessive urination. As a matter of fact, especially young type 1 diabetics, usually diagnosed between the age of 8 and 15, are often first diagnosed with diabetes mellitus type 1 because parents notice that the child is getting up to go to the bathroom multiple times in the night. Because you're peeing a lot, you're losing fluid through the urine, so you get what's called polydipsia. You can spell polydipsia with an IA as well. That's usually the more common one, but some people do spell it with the EA. That means many thirst, literally. Because of the excessive thirst and loss of urine, you may get an increase in dehydration. That dehydration will also increase blood viscosity, make your blood thicker because there's less water in it. Because it's thicker, you'll have a poor circulation. The other thing that we see sometimes is something called polyphagia. Polyphagia means many eat, poly many. Phagia refers to eat. So people are often hungry because the cells are telling the brain, basically, that they don't have enough fuel because they're not getting the glucose. So those are just pretty common symptoms that we see. The big ones, hyperglycemia, high blood sugar, which results in glycoseuria, sugar in the urine, which results in excessive urination or polyuria. That results in polydipsia, and as I said before, they also get polyphagia. The glucose is often reabsorbed through the kidney by glucose receptors. Like all protein receptors in the body, they exhibit three primary characteristics: specificity, competition, and saturation. Specificity means that the glucose binds to receptors in the renal tubules, in this case the proximal convoluted tubule of the kidney. Competition refers to the fact that the glucose would compete for binding sites. The affinity and the actual concentration of glucose would determine how well it competed. And the third factor, which is probably the most important in terms of our discussion here, is the idea of saturation. Since there's a finite number of glucose transporters, they can become saturated when we have an excessive amount of glucose. Once we have all the glucose transporters active, we can no longer move additional glucose. So these glucose transporters are located on the epithelial cells lining the tubules, and their function is to reabsorb glucose from the urine. Because of the saturation aspect, they exhibit something called transport maximum. So here's transport maximum, is what you can see is as we increase the concentration of glucose, in this case, in the urine, the rate of transport into the cell goes up, so we can see this curve here. But when we reach what is called the transport maximum, that's 100% saturation. That means at this point all of the glucose transporters are full that are moving glucose. So since we can no longer move any glucose because of saturation, then some of that glucose spills into the urine. That saturation point varies from person to person. Could be as low as 225 milligrams per deciliter in the blood, and maybe I'll go up to 300 milligrams per deciliter in blood. So we can't see that for somebody if the glucose doesn't get excessively high because they've saturated the transporter. So that's called the transport maximum, or sometimes it's known as TM, T with a small subscript M. There are a couple types of diabetes that we can see. You can divide it up into actually 4 types nowadays. The first one is called type 1 diabetes, and in the old days it was called juvenile onset, and that's still not a bad description, as many of the individuals are diagnosed when they are younger. It makes up about 10% of the diabetics in the United States, and nowadays it's considered an autoimmune disease. An autoimmune disease is when the body does not recognize a particular aspect of the body being itself, so it considers it foreign, and it's targeted by the immune system and then attacked. So in this case, the beta cells of the pancreas end up getting destroyed by the immune system within a person, and it can no longer produce insulin. Once we destroy about 90% or so of the beta cells, then there's a significant effect in terms of having diabetic symptoms, and the only treatment really is to provide synthetic insulin. That would have to be injected or somehow get into the body because you couldn't take it orally due to the fact that insulin is a protein hormone. It would be broken down before it got into the body and absorbed in the blood. So the only treatment is synthetic. So sometimes these people are called insulin-dependent diabetes because they must take insulin as part of the treatment. The second type of diabetes is type 2 diabetes. It used to, again, be called adult onset because typically symptoms came about later in life, usually after the age 50 or so. And that makes up about 90% of the diabetics in the U.S. So the vast majority of people in the U.S. and the world, in fact, have diabetes type 2. This is typically more due to an insulin resistance problem. There's often an associated decrease in production or secretion, but it's usually the response by the receptors that is affected the most. Some people argue it's a downregulation of receptors, so we've decreased the number or sensitivity of receptors to high levels of insulin over time. It's still controversial whether or not that's really true. Causes could be many. Some studies have pointed to excessive visceral fat. That would be central fat. As people have advancing age, they tend to get some level of glucose sensitivity issues. Certainly genetics play a role, and possibly even diet. Again, some people argue that eating high sugar loads, especially the simple sugars that change blood sugar very quickly, would affect that. Treatments for type 2 diabetes are a little different. Exercise increases glucose receptor sensitivity to insulin, so that helps. Dietary changes may help. Some people eating more of a low carbohydrate diet or a ketogenic diet have success. Bariatric surgery, like a stomach staple or a lap band, often cause type 2 diabetes to go away immediately after surgery. And one of the more widely prescribed drugs in the U.S., sometimes known as metformin, actually its job is to inhibit liver glucose output by blocking gluconeogenesis. So about 10 to 20, 25% of our glucose a day actually comes from making glucose in our liver, and by blocking that, you can reduce the blood sugar enough where you can move somebody out of the diabetic range and into a more normal or even pre-diabetic range. The other two types of diabetes, one is gestational, that's known as pregnancy onset diabetes, and nowadays the type 1 and type 2 diabetes are often used or diagnosed using a fasting blood glucose, but gestational diabetes is still often used in terms of a glucose tolerance test. So it's a little more rare to have a glucose tolerance test, but in the U.S., all women that are pregnant, it is suggested that they are screened for diabetes, and most physicians believe that a glucose tolerance test is the best, most accurate way to do that. So that's why we see it most often used during pregnancy. Gestational diabetes occurs potentially for a couple reasons. One, because the fetus gets all of its nutrition from mom and her blood. The placenta, which is the attachment between the fetus and the mother, produces hormones that keep blood sugar high, and that helps support the developing fetus. In addition, the increased body weight and cell size of a pregnant female may decrease insulin sensitivity as the insulin receptors move farther apart as the cell size increases. That will likely go away after pregnancy, but not always. And so, there is some indication that people that have gestational diabetes increase their risk for type 2 diabetes later in life. But I have also seen it argued that people get gestational diabetes because they're already at increased risk for type 2 diabetes. The fourth form of diabetes that we see, is called gestational diabetes. Gestational diabetes, emerging diabetes. So the fourth form is emerging diabetes. And there's various types of diabetic forms that we really haven't seen in the past 25 years. It's just these new cases that we haven't seen. There was a time where if you usually made it to about age 15 to probably age 50, you didn't have to worry about developing diabetes. But now we see people in their 20s and 30s that are becoming diabetic. We're seeing 3, 4, and 5-year-olds that are developing type 2 diabetes and things like that. So those are all kind of hatched into the emerging diabetes, and we're not going to worry too much more about those. So, gestational diabetes, a little more detail on it because that's what we use the glucose tolerance test for primarily in a clinical setting. What happens is when a woman is pregnant, her body makes excessive hormones, and these hormones affect the pancreas, and the pancreas produces less insulin, and the lower insulin allows mom to have a higher blood sugar. This occurs in about, 2 to 5. I've seen as high as 12% on different studies for gestational diabetes. So, there's, some relatively small number of women that have gestational diabetes. All pregnancies likely result in some level of glucose, changes. So some insulin insensitivity. But if it's not severe enough to reach the level of 126 and fasting, then it's not considered gestational diabetes. Again, the two major causes are placental hormones, which those boxes are supposed to be decreased. So right here is supposed to be a decrease in insulin sensitivity. And this box also is increased cell size, decreases insulin sensitivity, because we have the same number of receptors for insulin, but there's a larger area because the cells are larger, so the receptor density is decreased. One of the big problems with gestational diabetes is the baby gets excessive blood sugar because the mother's blood sugar crosses the placenta and feeds the baby, basically. And that causes excessive birth weights. We see birth weights last year in India. There was a baby that was born that weighed over 21 pounds, and mom had gestational diabetes. So that creates problems with delivery and often results in a C-section. So the baby doesn't have to be born naturally. And again, those, fetal sizes, you get more sugar, more calories, larger baby. As babies get larger and birth weights increase, that also increases the morbidity and mortality rates. Morbidity refers to the number, amount, or severity of diseases that the baby gets. Mortality rates would be the death rate. And the farther you get away from the ideal birth weight, the more likely you are to increase mortality and morbidity rates. So large babies do not necessarily have an advantage and actually have a disadvantage over more normal weight babies. And again, as mentioned, that increases the risk of developing type 2 diabetes later in life. And, again, depending on the study, somewhere between 20% and 50% of the women can be affected. This is just, some older data. So it's, this point when I'm making this, it's 10 years old. But if you look at the number of people in the U.S. with diabetes, it's, somewhere in the neighborhood of, 25 million. 10 years ago. It's now probably 35 million and increasing every day. And most of those are people above the age of 65, and it makes up over a quarter of that age group. You also can see certain ethnic groups tend to have a higher incidence of diabetes. Again, as mentioned, there is certainly a genetic component to that. So it just, kind of shows the different proportional risks in diabetes. So the bottom line is eat well and exercise, right? And that'll help in terms of those things. So actually looking at the data, I'm going to go ahead and looking at the data, we can see the blood glucose. All of these subjects are from all these data are from subjects in lab, except for the top one, that one up here that is in gray. That's subject number 5, which move down a little bit so you can see it there. Subject number 5, so that you can see they have diabetes. This is not a subject. I got this data off the internet, and it's not somebody who had in lab, but all the other data are. So just looking at it, and you can see subject number 1 is a 20-year-old female. Her fasting glucose was 68. That's a little low if we use 70, but we'd say that's right near the lower limit of normal. After 30 minutes, it reached a peak of 200, but then is back below 100 after 2 hours, so that's considered a normal test. For the second person, 42-year-old female, blood sugar starts out below 100, so between 70 and 99, so that's normal. Reaches a peak in 30 minutes again, and again within 3 hours back below 100. Subject 3, age 24-year-old female, 107. Fasting glucose, she reached a peak in 30 minutes, but note that her blood glucose slowly went back, and after 3 hours was still at 115 milligrams per deciliter. So that is an abnormal test right there, subject number 3. Subject number 4, 24-year-old male, normal glucose, peak after half hour, within 2 hours, certainly well within 3, back to below, so that's normal. And then subject number 5, 57-year-old male, start out above 129. Again, this is the data I found from the internet. We did not have this in class. Really didn't peak until after an hour, and is still way above 100 at 240 after 3 hours. So this is obviously someone who has diabetes. So to summarize, subject 1, 2, and 4 were normal tests. Subject 3 was pre-diabetic, and subject 5 was diabetic. If you look at the urinalysis data, note that in every case, for the normal tests, the subject had no glucose in their urine, so that was normal. We don't expect to see any glucose in the urine. Interestingly, for subject 2, which was the pre-diabetic data, we saw that in the 30-minute mark, they had a trace amount of glucose. So looking right there. And then subject 5, that was the diabetic one who had high blood glucose in their urine the whole time. So those are how we explain the data. So that kind of summarizes the glucose tolerance test and some of the important things that you need to know. So that's lab 19, looking at the data and the implications of that for the glucose tolerance test.